Dr. Pierre Kory. I think you all have heard of him in one way or the other. Dr. Kory is a board certified in internal medicine, critical care, and pulmonary medicine. He's the former chief of the Critical Care Service and medical director of the Trauma and Life Support Center, while an associate professor at the University of Wisconsin. Prior to this, he served as the program director of a pulmonary and critical care fellowship training program at Mount Sinai, Beth Israel in New York City. Dr. Kory is also considered a pioneer and national international expert in critical care ultrasound and is the senior editor of a best-selling textbook on the subject, which is in the second edition and has been translated into 5 languages and has won the President's Choice Award from the British Medical Association in 2015. Dr. Kory also considered a master educator and has won multiple major departmental teaching awards at each institution that he has served as a faculty. Our next uh, rock star, who just actually make his brief appearance, Dr. Pierre Kory. I described his bio before. He has been on the forefront of ivermectin. I think in many ways we can actually say that he has been the tipping point for ivermectin to actually start gaining traction that you are seeing now. I know that this traction is not sufficient, but the growth, the ball that is rolling at this time, Dr. Pierre Kory, Dr. Teslari, Bird Group, they're all actually very, very important in this. And the panelists who are here today, they are the ones who are actually keeping life in this and saving humanity. One quick note for the audience, please write your questions in the Q&A window instead of the text. It is actually difficult to find them from the text and bring them in here. So with this, without any further delay, let's listen in from Dr. Pierre Kory.
So I've been asked to talk about treatment protocols. So I'm going to present the protocols that myself and my colleagues in the Frontline COVID-19 Critical Care Alliance, that's the nonprofit that we formed. And although now we're so attached to ivermectin, I'd like to remind everyone that we formed a year ago to really just promote effective treatment protocols. Ivermectin came onto our attention only about 4 or 6 months ago. So I'm lucky to be president, although anytime I say that, I call out Professor Paul Marek, my friend, my colleague, my mentor, because he really is the one who brought us together to form the alliance. And, I would say he and I are probably the two that most have developed the protocols. I say, we borrowed protocols that Paul used for sepsis, and we've adapted and added to it through our reading and understanding of the pathophysiology of COVID. And one of my favorite things to do is argue with Paul about dosing strategies and drug strategies. The other thing I want to talk about is the protocols that I'm going to present today. So we really, I guess, would have 3, right? And we're actually working on a 4th. It's going to be a partnership with Dr. Bean, actually. We're going to be working on a long haul COVID protocol, which we'll probably have sometime next week. But right now we have a prophylaxis or prevention protocol, and then an early outpatient protocol, as well as a hospital one. Our hospital one's been around the longest. We are critical care doctors. Although now I'm treating patients in all phases. I've been treating numbers of outpatients for the last 4 to 6 months. They get to me, so I'm having a lot of outpatient experience. But these are brand new. So we've just added a few elements. I'm going to talk about them, but probably the easiest one to talk about is our prevention protocol. We just made a change. We used to dose every 2 weeks. Actually now, I'm sorry, there's a little bit of mistake. We're finishing this morning. Actually, for high-risk individuals, we are now recommending to dose weekly, like Dr. Carvalho's protocol. We had done it every 2 weeks, mostly because we were pretty impressed with the monthly data, as well as the weekly data. And we were sort of thinking about resource allocation And also, we didn't really have good safety data for long-term use. But now that it's many people in prophylaxing for a year, we have not come across any late phase side effects. And so we think it's quite safe. And really the best effects are weekly. So although it's miswritten here, the prevention for high risk individuals, those that are older or comorbidities, it's really weekly. And then the post exposure prophylaxis is actually one dose on the day that you find out that you've been exposed, and then you repeat another dose in 48 hours. And so that's what we do for post-exposure. And then for chronic prophylaxis, we advocate every week. And then we also have a number of supplements that we know are help the immune system optimize and protect yourself from respiratory viruses. And so that's our prevention. Now, the early outpatient protocol, we've had ivermectin. In fact, we first put together a protocol because of ivermectin. So when we put it together back in sort of October, November, it's because, Paul identified a pretty impressive data signal around ivermectin. This is after about 3 or 4 studies. Now we have dozens and dozens, and it's still argued about. But we were impressed with the first early ones, and we came up with a protocol centered around ivermectin. We've now just added 2 other elements. One is fluvoxamine, and then also nasopharyngeal sanitation. Now, nasopharyngeal sanitation, I'll talk about in a second. That doesn't have a lot of data around it, but it has very supportive and interesting data, and it's pretty harmless. And we know that, viral loads are very high in the nasopharynx. And there is really kind of supportive data showing that if you do, sanitization of the nasal and oral passages, by decreasing that viral load, it would seem that you could decrease the severity and progression of the illness. So we've put that on. There's a number of ways in which you can do it. From something as simple as doing inhaling steam 3 times a day with like vapor rub, some essential oils. That's a very good way to neutralize the virus. And then also mouthwash, gargles, and then even betadine nasal spray is another way to disinfect, and they're very virucidal. And so you can really reduce viral loads. And so we think that's supportive. The ivermectin, the other thing that we've changed, we always had the standard dose, right, which is 0.2 milligrams per kilogram. And, we said a minimum of 2 days and go out to 5 if you're not fully recovered. Many people, especially if you start early, they recover fairly quickly. But now we're actually increasing the dose for a few reasons. Dr. Hill's data showing a pretty strong dose response in terms of time to viral clearance, as well as time to clinical recovery. And then also we're just getting, I'm in contact with doctors all over the world, and we're hearing that in some of these more aggressive variants that the standard doses really are underwhelming, and they're having to use higher doses. So we actually are putting up our range to 0.4. And even myself, I've had a number of cases recently where I did not get the same responses that I have been with the standard dose, which worked well for me for quite a few months, and I've had to double the dose. And so we're actually putting up a higher range. We give some indications of when you'd want to use a higher range. The other thing that we've been doing is the fluvoxamine evidence base is pretty strong, relatively harmless at these doses. And we are now, I've been using it for my more severe cases where patients get to me after 5 days and they're a little bit farther along or in the pulmonary phase. I add fluvoxamine, and that's the dose is from the Seftel study where he modified the dose from the Lens study. Anyway, we do 50 milligrams PO twice daily. I say 10 to 14. They did 14 in that, but I don't know why you'd go out to 14. If you get better and you've recovered relatively easier, I think you could stop earlier. And so we have that as an addition to ivermectin in more severe cases, more advanced cases, or numerous comorbidities. We think in combination, it's highly effective at arresting this disease. And then obviously we continue on with our supplements. So just briefly, this is from Andy Hill's data. It's actually gotten stronger now. This only has a handful of studies, but if you could see the treatment effects of single-day dosing versus multi-day dosing, and that's actually much stronger now in terms of time to viral clearance. In fact, there's 10 of the 13 studies that have measured viral clearance including Dr. Schwartz's, show multi-day dosing far more impactful than single day. And there's even a signal there for clinical recovery. Obviously, there's only one study here. There's more, and it's consistent for time to clinical recovery. So that's why we're actually, not only do we have multi-day dosing, but we've actually increased our dose. Fluvoxamine, I'm not going to go over this too much, but there's actually two clinical trials. One was an RCT in JAMA. The other one was more of an observational trial. But there's just a lot of observational and confirming studies, the observational studies from mental hospitals showing that in outbreaks in mental hospitals, all the doctors and nurses got sick and very few of the patients. And when they looked at why, it looked like these SSRIs were quite protective. And then the androgen blockade, which I'll talk about in Math Plus, that actually has pretty robust evidence. The one study of proxalutamide, I haven't seen the study yet. It was just more of a press release, but they were reporting mortality that is almost unbelievable. I think the control group had a 48% mortality. It was in the Brazilian variant where they were overwhelmed in Brazil, and the treatment arm had like a 3.7. So I'm very interested in seeing that study, but that also seems to be an intervention that's lining up. This is just from one of the experts who did a review of all of the different methods in which you can do nasopharyngeal, oropharyngeal sanitization, the different ways in which you can do that. And so we favor that. It's pretty harmless and likely quite helpful. Now let's move on to Math Plus. So this is a two-parter. So this is one slide. This is the second slide. We got a lot of stuff on here. So this is what we first came to prominence for, is that we argued for methylprednisolone and at much higher doses, and I'll explain why in a second, but there's an epidemic of underdosing of corticosteroids in the hospital. We also are experts in the use of ascorbic acid, and so we favor that. We've been getting really good results, especially in late phase severe disease with megadosing. There's a little bit of literature on that, a case report from Belomo in Australia, and we are actually seeing a number of cases of pretty much rescue therapy with these megadoses of vitamin C. Thiamine, there was just a study that came out this week, showed a mortality benefit from thiamine in COVID. And then obviously, you guys know about anticoagulation with heparin. So we had this down already in March or April of last year. So the math hasn't changed. We have changed our dosing a little bit as far as we're much quicker to go to pulse dosing now, and I'll explain why in a second. And then obviously we have ivermectin, and here we're actually favoring a higher dose range, 0.4 to 0.6 in the hospital in more severe disease. So it's Math plus ivermectin. And then in this slide, we're also adding fluvoxamine like we do in outpatients. And this is where we add the antiandrogens for men only, either dutasteride, which was in the studies, or finasteride. And we don't have studies on finasteride, but it should be a reasonable substitute. And then obviously we have other interventions like statin, and then some of our other supportive medicines. The therapeutic plasma exchange is another one which I just am so saddened about. It is so highly effective. I've rescued patients by doing plasmapheresis. I've seen turnarounds like you wouldn't believe. The data supporting this in severe cases is overwhelming. I would refer you all to our paper on Math Plus, which is published in the Journal of Intensive Care Medicine. I have a whole section going over all of the case series and the observational controlled trials of plasma exchange. And it's really a very highly effective salvage therapy that's underused and not talked about. I want to talk a little bit about steroids. Maybe this is me tooting my own horn. Maybe these are my resentments coming out, but I think everybody remembers my testimony in the Senate in December when I talked about the critical need for ivermectin. That was not my first rodeo, as they say. I had already been in the Senate back in May, where I recommended that it's critical that we use corticosteroids in this disease. And I did that at a time where every major national, international body was recommending against steroids. And I got roundly attacked and criticized for this recommendation. Everybody thought it was reckless and that it was going to hurt people. I was extremely competent. Our team was extremely competent in why we were recommending, and we turned out to be right. So 6 weeks later, after my testimony, the recovery came out showing that dexamethasone saves lives. I was very happy by this, but I'm also saddened This trial is, I think this is what I say. It helps the few and fails the many. It is a terrible dose of steroids and the wrong steroid to use in this disease. And I find it a shame that the whole world sticks to this protocol of 6 milligrams of dexamethasone. And I'll tell you why in a second. Now, one of the important reasons why corticosteroids are critical, I'm not going to get too into this because it gets a little geeky, but remember, I'm a lung specialist. And I thought these patients, it clicked one day as I was seeing these patients that, they remind me of these organizing pneumonia patients. And I'm friends and colleagues with one of the world experts in chest radiology. And I called him up one day and I said, hey, Jeff, would you agree that these patients they all seem to have organizing pneumonia? And for those of you guys who don't know what organizing pneumonia is, it's not an infectious disease, although it's a terribly named disease. It's not an infection. It's just a response to a lung injury. It's a type of inflammation that occurs when the lung is injured. And he told me, he said, of course it's organizing pneumonia. We published this back in March. So last year, not March 2013, in March of 2020, the expert panel in radiology, they said that the most common reported CT finding is one of an organizing pneumonia. And the pattern now is described in almost every case. Everybody, when they first hit the hospital, has a pattern of organizing pneumonia. It's a response to a lung injury. And I wrote a paper trying to call attention to the world that this is a pandemic of organizing pneumonia, and you needed steroids, and you needed high doses of steroids. My paper was roundly rejected by all of the big journals. It actually went out for peer review at Chest, and the reviewer rejected it, saying my little hypothesis could not be accepted unless I did a big RCT of corticosteroids. So now that the RCT came out, people are starting to say, hey, we're seeing a lot of organized pneumonia. I have trainees all over the place who text me or call me when they find this paper, because I published this paper in BMJ Open Respiratory Research, really showing that in organizing pneumonia, what we've known for years in this disease is you really need to do pulse doses in fulminant cases. They don't get better on these low doses. 6 milligrams of dexamethasone is a joke. I'm a pulmonologist. I treat 80-year-olds with COPD exacerbations with more steroids than this. These patients are on ventilators with whited out lungs, and they're getting 6 milligrams of dexamethasone. I find it sad and depressing. Literally, a year later into this disease, the entire world is giving remdesivir and 6 milligrams of dex. It's embarrassing. It's absolutely embarrassing to show such little knowledge and insight and accumulation of experience in treating this disease. And the other important thing about organized pneumonia, not only do you need high doses, but there's no preset duration. These patients can relapse. I've had patients discharged from the hospital off oxygen, and they've come back in with fulminant relapses, and they've died. People can die if you take them off steroids too early. So my point is, you need to treat for longer. You need to follow the disease. There's no preset duration, and you have to watch for relapse. I treat until they're off oxygen, then I taper over 2 to 3 weeks, and I watch for relapse. I have my patients call me immediately if they feel any more recurrence of shortness of breath. Now, this table is what we put together with all the RCTs of steroids in COVID. And if you look here, this is number needed to treat. That's what measures, that's the most potent way to measure the impact of a therapy. And this is the number needed to treat to save one life. Look where methylprednisone lines up compared to dexamethasone as well as hydrocortisone. It has the lowest number of needed to treat. This trial used the highest doses, 250 milligrams of methylpred daily for 3 days. And look at this mortality benefit that they realized. Compared to this anemic recovery trial, it's just sad that these patients are being underdosed and they're using the wrong drug. The drug is methylprednisolone, and it's at higher doses. And I don't know how long it's going to take for the world to fill that out. We even now have studies where they've compared the two, and both studies show dramatic benefits of methylprednisolone versus the dexamethasone 6. This is an example of organizing pneumonia. It has a very characteristic, these well-demarcated peripheral ground glass opacities that don't follow anatomic planes, with all this central bronchovascular involvement too. And this was a patient, actually was a doctor, 10 days on heated high flow, 100%, got pulsed and was off the high flow within days. And this is what happened. This is how she got discharged. The last thing I'll say is contraindications. So what is the safety of of ivermectin, the first thing I want to say is there was a recent sort of big review of 350 reports. It was done by a famous toxicologist in France. And in his review, it's actually on the MedinCell website, his overall conclusion on ivermectin is that severe adverse events are unequivocally and exceedingly rare. Unequivocally and exceedingly rare. It's an extremely safe drug. The only things you have to watch out for is that we have, not everywhere will you find this, but I have heard of an interaction with statins that in rare cases it can cause rhabdo. With warfarin, it can actually prolong the coagulation times. You have to watch it with warfarin. You might want to hold it if you're treating together, or just do much closer monitoring to make sure that they're not over anticoagulated. Transplant medicines are the big ones like tacrolimus, sirolimus, and cyclosporin. You really need to monitor those levels, and you would have to tell their transplant doctors that you're using ivermectin. The only absolute contraindication is BCG and cholera vaccines. And like I said, there's no contraindication with liver disease. And this idea that it injures the liver, we could only find 3 cases of hepatitis in the literature, 3 cases in 40 years. They all self-resolved, and one of them was weak. It occurred like a month after treatment. And like I said, the insert says no dose adjustment indicated liver disease. And with that, I'll stop. Thank you for having me, and I hope you guys learned something.
Thank you very much, Dr. Kory. Such a great presentation and great work. So it is actually an honor to have you with us. We have a number of questions. So when you're ready.
Born ready, Dr. Bean.
Excellent. So let's start. So the one question is about clarithromycin oral and usage of oral clarithromycin. Does that somehow interact with the liver enzymes and then increase the dosage of ivermectin? Should we reduce the dose of ivermectin?
So I'm a little bit ignorant on the interactions of both of them. I do not believe that they interact, number one. Actually, that's the other thing I should say is that if you look at drugs.com, there's actually a long list of interactions in terms of either the levels of ivermectin will be higher or lower. So always consult, that database. If clarithromycin lowers the levels, then yes, you might want to increase the dose of ivermectin or vice versa. I don't use macrolides in this disease. The data has been very underwhelming. I get that there's some pathophysiologic rationale, but we don't use it.
Yeah, so there is a mechanism about the P-glycoprotein, which is a transporter in the liver cells and possibly works with the ivermectin, as you very well are aware. So I think that the right answer is to look at the drugs.com and the interactions over there.
Yep.
Moving forward, this is an important question. Will the big companies, big organizations, big pharma, will they repackage something like an ivermectin molecule with different names and then sell them with higher prices?
I actually saw that question.
That's why I asked.
I mean, the only reason I'm laughing is it's a very good question. I wouldn't doubt that pharma would do that. It sounds like once they realize, or they probably already realized that ivermectin is effective. If it's a pharmaceutical company that doesn't have a competing molecule, and many do, even AstraZeneca has a couple. And so it's definitely not going to be AstraZeneca because they have other drugs that they want to bring to market. But if there is a pharma company who wants to somehow make a patentable or a profitable package, it certainly seems like that would be a strategy. I would not be surprised. Dr. Carvalho, what do you think?
Well, I think so, and I can give you an example from my country. There are 4 companies in Argentina who sell ivermectin. One of them have created a new formula, concentration, increasing the concentration 3 times and increasing the price 10 times. So it's part of human nature. There's no vaccine against greed.
Right. I'm sorry, I like that statement. But yeah, when I said this would not surprise me if a pharmaceutical company did this, and there's your example. So
And one more example from the US as well. I would not name the company, but recently there has been a drug that is our DRP blocker or disruptor. The mechanism of action is very similar to ivermectin. Just keep in mind that ivermectin has 5 mechanisms. RDRP disruption is one of them, but this new drug only has that one mechanism. So this is happening. One more question for you, Dr. Kory. Here in our country, US, since this is not yet FDA approved, ivermectin, how can we protect our licenses if we are prescribing it?
So I'm going to give a strong answer to that one. I believe that is an overblown fear. So number one, prescribing something off-label is about as common as the day is long, right? 20% of prescriptions in this country are off-label. So why you would be scared of off-label prescribing of ivermectin makes no sense, because you do it all the time. That's number one. Number two, I can't imagine a courtroom or a case in which you would lose. I would come on as an expert witness and I would show the pile of data showing that not using ivermectin harms patients in COVID, and really that it's very well supported with the evidence. Now, the challenge is none of us want to go into a courtroom, right? And so, but I think it would be nearly impossible to get sued for using ivermectin. Do you know how many patients are grateful? How many reams of testimonials and all the patients that we've treated who feel better? Hector, what you please add to that?
Well, I'm here just to interrupt you. Yeah? The fact is, you have to take, and I'm not talking to you, Pierre, because I know you do know this, but to the audience. First of all compounds, these compounds, any other compounds, are meant for compassionate use. So if you make the patient or his relatives sign for the compassionate use, no one can ever even dream of suing you. That's compassionate use. And secondly, if you don't want to write so much because doctors are not good writers, well, you may prescribe it for possible strongyloides. And that's it. That's what they do in Argentina. Many doctors prescribe it for parasitic diseases. And who can blame them?
Hector, I like that suggestion. I didn't think of that. You know, if for those that are concerned, I think if you were to show, some of our summaries or our paper to a patient, they would be very swayed that there's sufficient evidence. But you can also protect yourself with having them sign for compassionate use. I think that's fine. I don't do it because maybe I'm overconfident, but I mean, my patients they understand I'm an expert in the medicine and in the disease, and they trust my judgment. And I've done nothing but help patients with this protocol. So anyway,
well, I don't do it either, but I'm given just 2 possibilities of using it if some doctors are concerned about their future.
And I also want to just secondly have to mention that this lack of guidance from the PHAs, the public health agencies all over the world, is a major problem. The fact that doctors have to be worried about their license and about being, being blamed for something because they can't give good guidance is really, it's harming physicians. It's harming patients and physicians, and it's truly sad.
So Professor Schwartz, please.
Yeah, I just want, mentioning strongyloides, I think it's a good point because we have to remember, especially if we are talking about high-risk patients, they may deteriorate to hospitalization and they would need dexamethasone treatment, which become a standard of care. Now, you have to remember that all patients who are living in endemic countries for strongyloides, they may be in danger of strongyloides hyperinfection. So it must be to protect them, you have to give them ivermectin before dexamethasone. So the fact that somebody is high risk, either he's a traveler returning in his past from endemic countries or is residing now in endemic country, I think it's a good excuse to give anyhow dose of ivermectin.
Makes sense. And I want to loop in Dr. Chesler here as well. Dr. Chesler, you have been using ivermectin in some of your centers too. You discussed them yesterday. Uh, what is your opinion when you are using it?
Well, we informed all the responsible parties that we were going to use this medication and explained why I thought it was going to help and that the chances of side effects were so minimal. And everyone was just so excited that somebody was going to do something because they all knew what was ahead for their loved ones. And so never had any pushback from families.
Got it. Thank you very much. Dr. Laurie, how about Britain? So the same thing, the prescription, I believe that in Britain, it is not prescribed very often. How do you see it? Dr. Medhi, if you could chime in as well.
Yeah, can I go next? I mean, I'll be talking about this specifically from the UK NHS perspective in my talk later on.
Okay, so we'll wait for this one for that. I'm going to switch the question then for Dr. Kory.
Has been said so far. I just
We'll wait to hear from you. Dr. Kory, I have a question for you. Animal ivermectin. This is such a big question, and it is an unfortunate situation that because of the fear of the ivermectin or not approval of the ivermectin, people don't get them, and then they go and get animal ivermectin. Any comment on that? Good, bad, don't do it, no comment.
Yeah. So here's the things I have to say on it, because you're right. It is a common question. And I'm just going to give an honest answer. So two things. The differences between animal and human ivermectin is that they're both ivermectin. The human ivermectin is generally regulated to have very low amounts of impurities. So there's more impurities in the animal forms. Now, are those impurities toxic? We have no evidence that there's toxicities associated with the animal ivermectin. I know the FDA has warned or tried to scare people by saying people have gone to the hospital, but we don't know if they took too much. And even if they took too much, we have papers showing that even very high doses, there have been overdoses, accidental overdoses, and people haven't been harmed. So what I say is, although the animal forms we don't have safety data on, we also are not aware of any toxicity with it. But as a group and as a physician, I can't recommend animal ivermectin. We don't have the safety data on it. But at the same time, knowing that we've had very little toxicity data, and maybe Hector, you could speak more about this, because I know in South America, especially in Peru, I mean, hundreds of thousands of patients used animal forms of ivermectin. And so I know it's commonly used, but I can't personally recommend it.
I know that many people are using the veterinary form all over the world, not only in South America, but also in Europe, because in Belgium, they receive, not in Belgium, in the Eastern, Europe has changed after the drop of the iron curtain, but the fact is, it wasn't dropped at all. It was just moved a little bit eastwards. And so the countries that are close to Russia still receive ivermectin in the veterinary form, and they use it for human reasons, mainly for the COVID-19. So that happens both in South America and Europe. And the fact is, there's a difference in concentration. The concentration is 1% and 0.6% if compared with the medical form. And besides, the propellant, which is used for injection in a bed form, the propellant, which is polyethylene glycol, is maybe toxic for human beings, even if they receive it per os. Have I been clear about that point?
Yes.
I'm more concerned about the propellant used by the veterinarians than from ivermectin itself.
Got it. Thank you very much for this answer. More questions. Dr. Kory, you ready?
Yeah.
Next question is from Dr. Resend. He is saying, or they are saying, I see many colleagues using many new medications for the treatment of COVID. For example, dutasteride and etc. As the disease already causes liver changes, Wouldn't they be overloading other vital organs in addition to liver? Why do I ask? Because I don't use all these new medications. I only treat with ivermectin plus vitamins plus probiotics plus azithromycin. Could talk about this question. Any comment? Using new drugs, overloading liver and other organs.
Yeah, I mean, obviously, as more data comes, we can be more certain in the safety, but I am not aware of any adverse effects from those anti-androgens, nor fluvoxamine, and both of those are the ones that we've added to our protocols. And I would say if your protocol is working and or you're seeing patients early in the disease and you're able to turn them around, don't change what you're doing. I mean, I go to work with two principles every day, which is I use the phrase, if it ain't broke, don't fix it. Meaning if my patients are doing well, they're improving, they're having a trend, I do not do anything different. But if what I'm doing is not working, I change what I'm doing. And so if I find a patient's not responding, I think you should avail yourself of those other options that work on other pathophysiologic mechanisms. Because some of these patients, especially later on, especially when I see someone coming into my ICU, they're almost always undertreated in advanced disease. And so I really have to throw a lot at them. And I don't know if the questioner works in an ICU, but it gets real different when you're that late phase disease. It can be quite hard to turn people around.
Got it. Thank you very much. Chris Williams has a question, and Dr. Carvalho, if you could, or Dr. Chesler, anybody who can join in. The question is, would you recommend the combination of calcifidiol, vitamin D, with ivermectin for treatment? So is there any combination that is specifically important to give with ivermectin, or ivermectin on its own is good?
Well, ivermectin has been used alone, which I think is it's not correct, because I'm against anything that may be considered a silver bullet, because silver bullets have proved to be good only for the werewolves, as far as I know. And pretending to solve a situation with a silver bullet is too risky. So I think combinations that we have done with corticosteroids, as Pierre said, from early April last year, with aspirin and so on, is the right way to deal with this kind of situation we are living now. And the combination with vitamin D has also been published, and I guess it also works. It's good. It's reasonable. The only thing which is not reasonable is to do nothing, to stay at home in our comfort zone with the complicity of the sanitary authorities that say that nothing can be done, just paracetamol and remain home and God bless you. And that's the worst thing a doctor can do, to do nothing for his patients. That's criminal. We have we have given an oath not to do that, just to make our best effort, not to remain at home and do nothing. So which is the best way to use it? The way that works for your patients.
I agree with everything that Hector said. He and I are of the same mind. We're both, yeah. The one thing I want to add is calcifidiol is on our protocol, right? So we actually recommend, especially in Math Plus, you have to use the more, the closer to active forms, especially late in disease. Regular vitamin D, like cholecalciferol, doesn't seem to work once you're acutely ill.
Totally makes sense.
We do the combo.
So next question, thank you very much for this one. Next question is more on the dosing side, and I know that Dr. Kory, you talked about it a little bit. So Roberta says, we always use ivermectin 0.3 milligram per kilogram dose, 3 days associated corticosteroids in our ICU, 18% lethality. We have to remember that lymphopenia is a major mortality risk at a call score to COVID. So what dose in ICU patients?
For steroids or for
ivermectin?
So we are going to 0.4 now. We have the range 0.4 to 0.6. We have colleagues in Zimbabwe who had just a lot of success, no problems with the 0.6. When they had their huge wave, they say that on the ground now in Zimbabwe, which interestingly did not have the mass vaccination that happened in Israel. In fact, they've had like no vaccinations, but they have like 0 cases and 0 deaths right now. It's very quiet on the ground, and they used a lot of ivermectin. They were using 0.6, but I would use 0.4, and we go out to 5 days. Again, you got to follow your patients. I don't really like in sick patients to have a predetermined duration. You need to follow the day-to-day responses of your patients. If they're not improving, you go higher doses. If they've gotten better, you can decrease or stop. But yeah, I wouldn't do a predetermined 2 to 3 days unless the questioner really has great responses and they're heading out of the ICU after 3 days. Maybe they're right.
Totally makes sense. And my own.
The steroids. Did I mention the steroids? I don't know if the question is on steroids, but for the steroids, if you look at our Math Plus in the hospital, we say 80 milligrams of methylprednisolone as the starting dose, period. You should get 40 milligrams IV BID. And that's what we start in a hospitalized patients. Once you're in the ICU and you have advanced pulmonary phase, we recommend pulse doses, and we have on there 125 to 250 Q6. We actually clinically are getting really good responses from 1 gram daily. The classic, severe autoimmune protocols. We actually are seeing even better responses by just doing 1 gram a day. And we do that for 3 days. And so that's our pulse nowadays. And so it's 3 days, but we've seen remarkable turnarounds with that strategy.
Excellent. Thank you very much. And just a comment here, for my patients, I use ivermectin till they come out of the symptoms. Their oxygen improves, they're feeling better. I don't go with 3 days or 4 days. I just continue. Now, a couple of questions here, and I think I would have Dr. Laurie come in as well for this question. So Dr. Kory, first to you. I had heard a comment that WHO's announcement that ivermectin is not to be used. And you had said that, hey, WHO may not be relevant in these discussions anymore. They put themselves in that state. I'm putting words in your mouth. The question is, don't you think that they have actually taken a position that has harmed some patient benefit that could have happened with the ivermectin use, and now more doctors and patients will be hesitant?
Oh, I think it's incalculable harm, and I find it. I mean, I can't believe what I'm learning about life as a physician in COVID. I mean, I am discovering things that I have to say I was very naive about before. Everyone would say they're corrupt, they do this, but I'm witnessing with a front row seat. I'm witnessing what I've talked to you about a little bit is that this is a disinformation campaign. The number of, or the scale of the market of profitability and the number of players who would lose hundreds of millions, if not billions of dollars by the recognition that ivermectin is effective in COVID is so vast that you're seeing how this is playing out. The WHO, unfortunately, has shown itself over the last 250 years. They're not really a scientific organization. Their heyday of from the 1940s, 50s, and 60s, and the wonderful things that they accomplished for global public health, those days are gone. They're a compromised organization. We have any amount of evidence to show that. And they're under the influence of pharmaceutical interest, and particularly the vaccine lobby is what I'll call it, even from nonprofits that are trying to globally vaccinate the world and all of the vaccine industry. They really can't have ivermectin out there. It'll increase vaccine hesitancy. And so it's almost unsurprising what the WHO did. In fact, my team, we all were expecting it. We were all expecting for them to do exactly what they did. And when you ask about how harmful that is, all I can say is, and I believe there will be a reckoning. And when you look at this, when we look back at this time historically, this is going to be a massive stain on the record of WHO. It's going to further put their reputation into the garbage. Really, it's terrible.
So Dr. Kory, once again, thank you very much for coming on. Thank you very much for the insights and answering those questions.